So this is Sarah, and she is presenting with some leg pain. And I have not looked at it before, and we thought that this would be a good opportunity for us to capture a video clip of me thinking through a process and maybe doing a little bit of an intervention. So the assumption is with this that we've already done the regular full intake. In order for us to stay in the frame, we're not 6 feet apart, but that's okay. When I do the intervention, the assessments and the intervention, these would be woven right into the massage. So I know you already, and you've done something, and now you have some symptoms. So why don't you tell me when this started?
It started off when I was in the middle of a run. I'd already run for about 2 miles, and it's after about a month of regular running, where before that I hadn't hardly done any.
Okay.
And so I was about 2 miles in. I had been doing a regularly 4, and all of a sudden it hurt for me to pick up my left foot at the ankle.
The left one.
The left.
So
the dorsiflex.
Yeah. Which one is it?
The left.
This one. Okay. And so show me what actually hurts.
To do that.
It hurts to do that.
Not anymore.
Okay, so that has improved, but that's where it started.
They can't see that, but she is doing just dorsiflexion of the ankle,
All
everybody.
Right. Okay, so then what happened?
So then I stopped running. I walked on it for a time, and then I resumed running slower, and I didn't have any more pain.
Okay.
And then over the next couple of days, I developed a lot more pain, and it was hard to identify exactly where. It felt like quad, it felt like the outside of my hip, it felt like it was going up into my glute. Just everything felt like it was inflamed and hurting in my left leg.
The whole leg?
Pretty much.
Did it go over to the side at all, or is it kind of stay contained up into the hip?
It's
and does it hurt only when you move it, or is it bothersome all the time?
the hip hurts even when I'm sitting.
Okay.
But everything else, for the most part, only hurts when I'm trying to move it. And I had more ankle pain for a few days after just walking.
All right.
But then I got some massage work done, and the ankle is pretty much resolved.
Did you hear a noise or anything when it first started? Had you changed your shoes?
I had gone back to a second pair of running shoes that I hadn't used in a while.
Okay. And had you run uphill or downhill?
Nothing really crazy.
Nothing different like
unusual,
that,
yeah.
but you did change the shoes. You'd be surprised how that will make a difference in your gait.
Yeah.
Had you run longer?
It was all pretty. I had done a steady increase over the last month, but nothing drastic.
Had you done anything else within 24 hours that could have reset the tone in the area, like standing on a ladder or
Not that I can remember. Nothing was really different.
okay. And you work with leader dogs.
Mm-hmm.
So had you been in a situation where you had been working with one of the dogs and they pulled, or you had to restrain them a little bit more?
That's highly likely, but I don't have anything
that you
that
can
I really
remember.
Yeah.
Because so many times we think about it happened when I did this, but the setup happened before.
And if I was to get pulled hard, it would be on my left side.
All right.
Yeah.
So this could have been something that had been set up already from what you do, and then whatever, and it was enough to bring on some symptoms for you. So where are you at right now?
So as of now, this morning, I was able to work my 4-hour shift with more noticing discomfort down into my quad, kind of on either side of my knee, and reaching up into my back left side.
Is it a steady pain that goes everywhere, or is it more like a line?
Probably more steady.
Steady.
Yeah.
Does it feel like it's fat or ballooned at all?
No. And I will say also that it got better after sitting in the car and driving around for about an hour.
It improved.
Yes, and then I was upstairs and did like a 15 minutes of a high intensity, like mostly upper arm focus, but even just stabilizing myself with that leg made it more in my consciousness.
Okay. Could you can you poke at an area point that's you?
Right in my like
Okay, so
whatever that is.
so back.
Back, yeah.
All right.
And then depending on what I'm doing too, I would say like along the outsides of my quad.
All right. So when you demonstrate that to me, you really are drawing lines,
Okay.
and when I see lines, I think nerve.
Okay.
An actual nerve track as opposed to just generalized neural activation. And if you were going to fix this, if because you're familiar with massage, what would you do?
So
what do you think you need done?
Well, I have what I naturally wanted to do upstairs while I was working out was try to like do stretches that sent my arm up overhead and like did that
Okay.
to like twist and stretch. Like down dog.
Okay.
Positionings feel good. I honestly feel like I love to foam. I don't have a foam roller, but I love to foam roll my quad.
Okay.
Stuff like that.
All right. So let's see what your general stability looks like. Luke, do you need to change the camera?
Let's do a pause. 3.
So we've repositioned ourselves. And remind me, it's the left leg, right? Okay. You know, I've got a little dyslexia. So when we assess, we want to assess the unaffected side first. And one of the very first things I do whenever there's a joint related or a soft tissue related is I want to look at what your general balance is. So if you can turn towards me and just like I'm going to demonstrate, just stand on. All right. This is the leg that bothers,
Yeah.
right? Okay. So I'm going to get a look. You feel pretty stable with that. Move your arms just a little bit. Okay, now let's see what happens when you do it on the other side.
I can maintain pretty good.
Do you feel it when you
Yeah.
feel it? And where do you feel it in the quad?
Yeah.
All right. But your stability was good.
Yeah.
And you didn't feel like you were wobbly.
No, which is
Alright.
a big improvement from yesterday.
Okay, so yesterday it did feel that way. So you could have had a little bit of a strain, muscle strain, or even a sprain in some area. Turn around so that your back is towards the camera, and we're going to do a teeny little quick assessment to see if it's an SI joint issue. So come over here just a little bit, and I'm just going to give you a little stabilization here, and I'm going to demonstrate what I want you to do. I want you to stand on one foot, and then I want you to lean back. Start with the unaffected side first, and then we'll do the other side. Okay? And then, do you feel anything with that?
There's a stretch up through the front, but other than that, it's
All right, and then the other side. Do you feel it?
in my lower back on the left.
Right here.
On the left.
On this side.
Yeah.
All right.
Kind of middle lower.
All right. But it doesn't ache into that spot that's bothering you at all.
That one, all right, no.
All right. So put your hand right on where you think it's coming from. All right. This is the side where you think the symptoms are coming from.
Mhm.
Okay.
Yep.
Right there.
Mhm.
So I can get my finger right on it right away,
Mhm.
and it recreates your symptom.
Yep.
So that's good that you can do that. Then we just got to figure out why.
Mhm.
Why it started in your ankle and now it's up there. And that's not uncommon. That's a very common thing to have happen. So I can't think of any other standing assessments. So let's pause this.
3.
So we're still assessing, and from this point on, I would probably just include all these various assessments right into the massage. I've got her supine right now. I could have positioned her prone or sideline. I'd still be looking for the same kinds of things. So I'm going to use palpation, and I'm also going to use some active and passive joint movement to see if I can still isolate stuff. So first thing I'm going to do is passive joint movement to assess for her normal range. So I'm going to bring it up, And this is a ball and socket joint. It's in its sagittal plane function right here, so it's a flexion. So 90 degrees and a little. So she's fine with that. You want to make sure that the movement happens without anything else moving. And this is the affected leg, right? From here, I can do internal and external rotation. And those are almost a little hypermobile, especially with the external rotation in there. And then you do it. Do you feel anything?
Some up into this section. But
Okay.
other than that, not really.
Do you feel it when I do it?
No, I didn't.
Only when you do
Yeah.
it. Okay, so let's try the opposite side here. And I'm working for the camera, not for body mechanics right now. So we would bring this up and we would check general range here. No other part of her body is moving. That's plenty. 90 and a little. I got my knee here. 90 and a little. External rotation is better on this side. And a little bit, I would call that pretty good. So we've got a little bit of increased external rotation in here, which is a hypermobile joint, which primes it for a little bit of instability, and that then can lead to your body having to catch itself. So let's just have you roll over on your tummy real quick. And I'm gonna go behind the camera, or behind the table. And I'm gonna, so this is the affected side.
It's my left, actually. So
It's this one, that's right.
Yeah.
You just turn your head to the side here. So we'd have our bolstering.
Do we need a flipper? Are we good?
You're
good?
I'm good.
Okay.
All right. So this is on the, I want to look to see if I can get the same sensation over here on the affected side, on the unaffected side. So this table's just a titch low for me, but we can I create that same sensation?
yeah,
on
you're
this
just
side?
about there.
Okay. So there's controversy about trigger points and all of that, but I think that they're a functional way of thinking your way through stuff. So right where I was at is the gluteus medius area, which is actually an internal rotator. And she was a little hypermobile on external rotation. And so it makes sense. All right, that this would have attempted to balance out some external rotation if you got yourself off balance maybe a little bit. All right, so we're going to come into about that area. All right, you tell me when I'm on it.
Yeah.
Right there. Now, does that feel good?
No.
No. Does it recreate the symptom?
Yeah.
All right.
Yeah.
All right. So here's what I want you to do. I'm going to show you what I want, and then when I tell you to do it, you do it. I'm going to have you bend your knee, and then I'm going to have you move this back and forth.
We have a screen change, and we have just a pause real quick. 3.
All right. So we're going to do I'm going to have you move back and forth like this, and we're going to do a little intervention. Give it a little try here. And this is an integrated method. It's a combination of muscle energy technique and inhibitory pressure and, but I isolate the area, recreate the symptom, have them move. That's basically what I'm doing here. So, okay. So I'm going to come in and recreate that. Just recreate it. I don't have to, okay, is that it? All right, so you're going to bend your knee. Can you feel that work up there when you do that? And then back and forth. So you're overusing this area just a little bit. And there's a lot of nerves under there which can, now that should be alleviating a little bit.
Yeah.
All right, so I'm going to just change my position just a tad and see if I can find another little hot spot, so to say. Is that it?
You're edging into it, yeah, right there.
All right. Good. Good. So now let's check a little bit of muscle strength and some firing patterns. Can you lift this leg from the hip? So let me show you what I want you to do. Straight up.
Okay.
Okay, can you do that? And I'm going to check and see if we got a good firing sequence on that, which should be glute first. Go ahead. One more time. So wait, you're using your low back. So,
Optimal firing should be glute max, high hamstring, opposing,
yeah.
low lumbar erector spinae.
So what we're going to do is we're just going to inhibit that area so she can't recruit it. And then I'm going to have you move the leg the same way. It's going to feel like it's harder to do.
So inhibiting lumbar erector spinae, and then having her activate opposite side glute max, high hamstring.
All right. So we've got some short calves there because it's hard for her to keep her leg straight when she lifts it up. She wants to bend her calf there. So, it's never simple. It's always a little bit of everything when we do that. So, but if you can start to create a more optimal function, lots of times it'll just sort itself out. I'm going to change my angle just a little bit. Okay. Yeah, see, right there. Broad base, no, not poking. I'm using not the point of my elbow. I'm using the flat of my arm. I'll show you. Oh, there, now that relaxed a little bit. So that should feel easier to do. And I felt when I say, oh, there, it relaxed a little bit, I felt like I sunk in. So I'm using this part of my arm.
And you can see that an important part of her being able to apply this intervention is to be able to apply pressure for a long sustained period. So she's using her forearm and good body mechanics to be able to lean and to hold that pressure long enough to get the change to occur.
And we got a little bit of the table's just a tad too low.
Yeah.
And I'm reaching just a little bit. But we're making a few adjustments for the camera. So less is more a lot of time. And that area that I was pressing on right there is part of the lumbar plexus that can refer all the way down to that knee pattern that you were telling me about. So as part of the general massage, that would be all the intervention I would use. I would see how she lifts this leg. Go ahead. Now that's pretty good. Let's double check the firing pattern. Go ahead. Yep, that's good. Let's double check and see if this is better again. Go ahead. You still want to use this. So let's the refe is here. So let's roll you on your side facing this way. So this side is up. Can you do that for me? So people want to call this quadratus lumborum and all that. It's where the front part of your body sews in and weaves into the back part here at the core. And that can become problematic as part of the stabilization unit in there.
Since it's a lot of muscles feeding into a unified connective tissue location, it lends itself to a lot of adaptation and symptoms. So it's where the obliques, quadratus lumborum, erector spinae, and even just the lumbar dorsal fascia, psoas. So as she's saying this, it's an important area to address, and that's a great example of utilization of side lying.
So what I want you to do is just, I want you to lift your leg like that for me. Can you do that?
So AB abduction.
Now I'm just observing. She doesn't look up. She's using all of her body up here. Let's do that one more time. And notice that she wants to recruit right in here. So this area is not being used as efficiently as it could be. So I'm going to come right in here. I'm going to recreate the symptom. If I can't recreate the symptom, then I'm in the wrong spot. And it has to recreate the symptom. It can't just be uncomfortable. So I'm going to scoot you a little closer to me.
As she does this, she's applying force. It's her positioning. I find optimal where your direction is going towards the hips / the ilium. It helps keep you from putting pressure on the lower floating ribs.
That's exactly right. So I come right into this, but I'm going this way. You can see I'm lined up for that. And you also can notice as she's on her side, she's lifted a little bit, and I'm able to stand up a little bit better.
Yeah.
Okay, so it's going to be down and then like that. All right. And I'm letting her, I'm stabilizing her right here, and I'm letting her lean up against me just a little bit. All right. So first, let's see if we can recreate it. Can you straighten your leg out? That's it, girl. Is that familiar? Does it recreate all of the symptoms, or which ones does it?
Everything in my hip.
Everything in your hip.
And into back.
Okay, so we are going to, I'm going to slowly go down. You tell me when to stop when you just start feeling the symptoms, okay?
It's already there.
All right, and then we're going to add a concept of positional release here. Can you move a little bit, move your hip or something and make it feel less intense? Okay.
You'll find it's not always a very big movement, but they're looking for a sense of relief.
And then can you position so it gets a little worse? So I'm using indirect, direct. And they're modulating it, so it's very safe. Right there.
Mm-hmm.
And then go to where it feels better again. My job is to just stay on the spot. So you had to exaggerate that. You had to go, that's good, because there was a change. And then again. Does that feel more tolerable now? Less scary, less ouchy?
Yeah, definitely.
Yeah. Okay, so do a lot of rocking and shaking in between what I'm doing. This would be again interspersed into the massage. So this is back to be a post-assessment. We're gonna see if it feels a little less intense. So I'm gonna do my best to apply the same assessment, pressure and direction that I did when I did the pre-assessment. So down and out.
Yeah, that's better.
That's a lot better. All right. Anything there?
Yeah.
All right. So I'm a little bit more into the oblique area. So.
And that's an important part to consider with being able to access the low back to the lateral side of the torso in this position, is you can get more posterior, working maybe lumbar dorsal fascia, erector spinae, but as she's working steadily more anterior, she's working maybe now more, this could be QL / the obliques.
So because I think it's oblique, just a guess.
Yeah.
The movement I'm going to have her do would be a pelvic rotation, like a hula hoop.
Mm-hmm.
All right. So we're going to find the spot right there. And so, you're going to do a hula hoop. Oh, I can really feel that work under there. Does that feel kind of good to do, even if it's intense?
Yeah.
All right. So the client should not be, my pressure should not be abrupt, it should not be pokey, and it should not cause them to tighten or flinch.
And to reinforce how she's interacting with the client, she's consistently asking the question, does that feel like it is correct? Does that feel like it's accomplishing something that's therapeutically valuable,
It feeds right into their experience.
yes, recreates the symptom, and the movement feels correct to do. Looks like feels like it's accomplishing something effective.
Okay, so let's pause the video. All right, so that was about as much assessment as I would do with something. And off camera, you let me know that you're annoyed by this. And that's very common, especially with some of these deeper, little ambiguous sensations that you can't find. They kind of persist. They do feel annoying. A mistake that happens with manual therapy is that you keep working at it to try to make it all go away. But if it can be 50% improved, and then your movement and your function is a little easier for a while, most of these things will sort themselves out. So that's what we're going to see. We're looking for about 50%. So let's start out with the same assessments that we kind of used. So unaffected side first, and stand on one foot and roll this. All right, and then the other side. Now you had to work at that one a little bit more.
I switched over faster.
Yeah, and also what that indicates, now you're stabilizing now, what that indicates to me is that there was a shift in the tone pattern or something in there. So that was good. That was good. Now if you hadn't been able to find it, then I would have actually been a little bit more concerned. The other one that we used was to have you start with the unaffected side first, stand on that foot and then lean back. You feel like that's a little bit better. All right, and then, well, that one wasn't problematic anyway.
Right.
All right, and then the other side. Now see, I can tell that that's better.
Yeah.
Because you're less hesitant, you're more
I felt less
confident.
guarded on it.
All right, now do a move that you think, an area that has been bothering you, like over at off camera you had moved a little bit and came down, you said it was still annoying.
I feel it a lot less tight just doing that kind of a rotation.
All right.
Which is nice.
So what I educate clients with is if you have to hunt for it, then there's probably enough improvement there. So I think we made enough shift, and then we would just let this settle for a while. If you do something that you think is aggravating it for a while, don't do that. Yeah. All right.